Ευχαριστώ πάρα πολύ για την πρόσκληση και χαίρομαι πάρα πολύ που είμαι εδώ και όλες οι ομιλίες προς το παρόν ήταν εξαιρετικά ενδιαφέρουσες. Και ευχαριστώ πάρα πολύ για την ευκαιρία να μπορέσω να δώσω την ομιλία στα αγγλικά. Όπως είπε ο Νίκος, πριν από 20 σχεδόν χρόνια είχαμε γνωριστεί και σε εκείνη τη φάση εγώ ήθελα να κάνω infectious diseases. Μετά όμως η πορεία μου άλλαξε και κατέληξα να είμαι professor of pediatric rheumatology. So in terms of clinical practice, I'm based at Great Ormond Street Hospital, and academically, most of my work is at UCL. And I've had a long-standing interest in Kawasaki disease, and I'll show you a bit about the work that we've been doing in the field, particularly trying to advance the treatments. So I'm going to break down my talk in the highlights in terms of improvements in understanding of the etiopathogenesis of Kawasaki disease, what's new in terms of treatment, and tell you a bit about the pain of my life over the last 5 years, which is this trial that we've been running around Europe called the KD-CAP trial. And then, obviously, the syndrome, which in the UK we gave a different name to, called PIMS-TS, but obviously in the rest of the world, and American, I think here you use this terminology, MIS-C, multisystem inflammatory syndrome in children. And I'll present a bit what we think now is the mechanism of this disease, how one can treat it and move beyond just the consensus really opinion on how best to manage this condition, tell you a bit about the clinical features and where we're up to now post the pandemic era. So just to remind you what Kawasaki disease is, so essentially this is a medium vessel vasculitis, and it has a predilection for the coronary arteries. I think it's important as pediatricians to remember the disease can affect any vessel. You can have arterial aneurysms everywhere in the body, but there is a predilection for the coronary arteries to be affected, and we're not quite sure why that is the case. The disease can happen anywhere around the world, and it tends to be that male patients get it more often than females. You can see the estimated ratio is 1.5 to 1. It's commonest in Japanese children, and that's where the description of the disease was very firstly made. In the UK, we see it more commonly in Black African children. Certainly, we see epidemics, and there tends to be a spring and winter peak of the disease. So I'm sure you're all familiar with the clinical features of the disease. What I really wanted to highlight in terms of diagnostic criteria is that, of course, the classic definition requires 5 days of fever and 4 of the following 5 clinical criteria. But if you have less days of fever and you actually have a full-blown clinical picture, then this is Kawasaki disease. So do not delay the treatment is a key message about how to manage this condition. So what's the cause of Kawasaki disease? Well, we think it's really a combination of nature and nurture. So all the genetic susceptibility studies that have been done have shown that there are specific SNPs, polymorphisms in specific genes that increase your susceptibility to get Kawasaki disease. I've selected 2 targets, ITPK-C and CASP3, because these are the sort of genetic variants that have been replicated in a number of GWAS studies. And if you think about what these molecules are involved in, they're involved in T-cell activation, cell proliferation, and immune responses. So they do make some sense. So you've got an individual that has this genetic susceptibility, and what we think then happens is you have this immunological hyperinflammatory state driven by a number of different cytokines, and you pick your target, and you'll see this have translated into different treatments that we've been trying to use to manage Kawasaki disease. The superantigen hypothesis is really attracting still a lot of attention. And what we're really talking about here is that you do have some viral or bacterial antigens that have the ability to really significantly activate T cells and produce a cytokine storm. So that's what superantigens are. So there's been a lot of studies showing that perhaps there is some superantigen-mediated inflammatory immune response in these patients. But then when you try to find the one single pathogen, the one single bacterial or viral agent that causes Kawasaki disease, the various efforts have not really been fruitful. There's no single pathogen that we can definitely say this is what causes Kawasaki disease. And I think all the environmental epidemiology studies are also interesting. I don't know if you've seen the papers published in high impact factor journals looking at analyzing the patterns of the wind between the Californian coast and then the Japanese coast. And they looked at what microbes, what pathogens were included in the winds, and showing that when the wind was changing between one coast to the other, you were then getting pandemics of Kawasaki disease. So their argument was that it's all in the wind. So who knows, I guess. Let's see. In terms of diagnosis, we talked about the clinical diagnostic criteria, but is there anything else that can be done in terms of a blood test? This group, based at Imperial, led by Mike Levine and Jethro Herbeck, have tried to see if there's a specific transcriptomic signature, so you're looking at gene expression, that when you see a patient just needing a few mils of blood in A&E, you can actually, in an accident emergency department, you can tell this is Kawasaki disease. So they came up with this 13 different gene signature, and they looked at validating whether this was working in their hands. Initially in the discovery cohort, and this is the first image you can see on the top there, this was clearly differentiating Kawasaki disease from patients who had definitive bacterial infections, definitive viral infections, or any other inflammatory state. And then when they went on to do a validation cohort testing, again, the cases that they felt definitely had Kawasaki disease or had highly probable Kawasaki disease had an upregulation of this gene signature. So they've been arguing for years that this is a good test for Kawasaki disease. Having said that, various other groups have tried to replicate the results, and we're awaiting for publication on what they've seen using this gene signature. What we're really worried about in this condition is, as we said, the coronary artery aneurysms, the coronary complications. And you can see some pictures here of saccular aneurysms in a couple of patients I looked after over the years. And the histopathological section is actually taken from a little infant. It is at post-mortem, so this infant died from Kawasaki disease. And you can see the terrible damage that's caused to the coronary artery vessel wall from the condition. So the theory always has been you use IVIG and you use aspirin. If you don't use this treatment, the risk of developing coronary complications is up to 30%. So the theoretic risk of bringing that down to 4% is what we've all been taught over the years and what appears in various textbooks. But we do know that some cases can be resistant to IVIG, and these are the ones that may be more at risk of developing coronary complications. And these coronary complications is what we're trying to prevent. And the bigger the size of the aneurysm, the greater the risk that these young people, whether this will be eminently or years down the line, will have a coronary artery event. There's a number of studies, and I've just picked to show you two, showing that actually the bigger the coronary artery aneurysms, you can see if they're bigger than 10 in terms of a Z-score, or an actual dimension bigger than 8 millimeters, then the risk increases up to 50%. And in this study, similar results. But also, this group was able to select that and identify the male patients, and if you were resistant to IVIG, you were even more at risk of developing these coronary complications. So as I said, the theory has always been that you bring the risk down to 4%, but is this really what actual data from across Europe has been suggesting? That's not really the case. I wasn't able to find data from Greek patients, and I'd be interested to hear your thoughts in the break. But in the UK, despite prompt access to IVIG, we're seeing an impressive number of nearly 20% of children developing coronary complications. So that's a really high rate if you think about it. And particularly for young patients, infants who have been less than 1 year old, this is up to 39%. We're not the only ones across Europe who have seen these high rates of coronary complications. You can see numbers from Sweden, 16%. The Russians are quoting 30% in their studies, the Germans even higher because they included some atypical cases of KD. So we definitely need better treatments to try and improve the outcomes across Europe. Steroids make sense because they've been used to treat inflammatory processes and to treat vasculitis for years. And actually, they've been used in Japanese trials for years now. What a lot of meta-analysis data suggests, and this is one of the most recent meta-analysis papers, is that high-risk patients are the ones that benefit the better from adding steroids up front. But how do you define these high-risk patients? In Japan, they have this score, and I don't know if you've ever looked at this, called the Kobayashi score. And it actually looks at different laboratory parameters and gives you numbers according to the values. And then the higher the score, the greater your risk of developing Kawasaki disease, developing complications from Kawasaki disease. But this score does not work for European patients. There's been lots of efforts to try and replicate, try to identify other risk scores that we can use in clinical practice and see whether we can pick out the cases that would benefit from steroids. That's not been possible. And as I've just shown you, the results across Europe suggest that the rates of coronary complications are much higher than any of us really would have thought. So how about we consider all patients in Europe and selected cases of Kawasaki disease as high risk and see if we can do better and treat them with steroids. So this is the trial. As I said, it's been the pain of my life over the last 5 years because it coincided with the pandemic, and recruitment to a study that was looking for Kawasaki disease patients has been complicated. This is the KD-CAP trial, and it's been done across Europe within this network that's called the Connect for Children network. It's a pan-European network, a spin-off of the PENTA infectious diseases network, trying to do clinical trials in the area. And we've been running this for years now with a lot of help from esteemed colleagues. And I'll just mention Nigel Klein, who passed away, I'm afraid, recently, and was really instrumental in helping us get the trial off the ground. So myself and Paul Brogan have been the chief investigators of this trial. And this is the rest of the team. Sarah Walker is a great methodologist and has helped us think about how we're going to analyze our data. And this is the rest of the team. So what we're looking at, and we're nearly in completion, is adding steroids up front to IVIG and aspirin and trying to see if this is an effective approach. In unselected cases, we're not selecting, it's any KD child. And this is how the randomization looked like. So in the control group, you just had your standard of care, so 2 grams per kilogram of IVIG and aspirin. And then obviously if the child became afebrile, you could drop the aspirin dose. And the experimental group got prednisolone, so 2 milligrams per kilogram per day, or the IV methylpred equivalent dose if they couldn't tolerate the oral dose of prednisolone. And then there were regular assessments, day 2, day 5, cardiographic assessments weeks 1, 2, 6, and 12, defining our primary outcome, which was the coronary complications. And the other point to highlight is that these assessments were not just looking at fever, because fever responses have traditionally been the endpoint in all these Kawasaki disease trials. We've added in CRP, really feeling, and I'd be interested to see what you all feel is relevant in your clinical practice, that you have to switch off the CRP as well. If you don't switch off both the fever and the CRP, you haven't really completely switched off the inflammatory process in these patients. So we've opened up the study in different countries, 55 different centers. I'm afraid we were trying to get Greece on board, but it wasn't really happening. And we have finished recruitment July this year. We've got 103 patients that made it through, and we're just closing the database, and we'll announce the results. I'm blinded to the results, so I don't know what the results will be in January 2025. And if we do show that just oral prednisolone makes a difference to coronary artery outcomes for these patients, it's a cheap, easy intervention, and let's see what the results suggest. And a huge biobank that comes with the trial will help us then in the next phase, and perhaps I can tell you about the story in a few years down the line, doing some ancillary biomarker studies and looking at all sorts of different things to try and identify if there's a personalized signature for responders and non-responders. Beyond our own efforts, is there anything else that's come to the scene in terms of new treatments? Well, cyclosporine is something that's been used in this trial in Japan, and it's been used up front together with the sort of standard of care treatment, IVIG and aspirin. And actually, if you look at the coronary outcomes, it seemed to make a difference. So it improved the rate of complications, coronary complications, if you added cyclosporine. And I think when you look at the breakdown, at what time point this was the people were seeing the greatest difference, this was at week 2. But then again, it was sustained across the different time points in an overall analysis. Fever also was coming down much faster, and CRP was responding, down-regulated CRP responses much faster. So how do we interpret this? Can we use cyclosporine in our own European Greek practice? I think not yet, because obviously this was a Japanese study, but what we've been doing in the UK is save cyclosporine for refractory cases. So if the patient is not responding to first-line treatment, you can use this. The same for infliximab. This is a monoclonal antibody that blocks TNF-alpha, and there's a lot of evidence that TNF-alpha plays an important role in this disease. This group, led by Jane Burns in San Diego, have spent years trying to show that infliximab could be a good agent to add upfront to the treatment of the disease. However, all the trials they've done show that that's not the case. So they now have been focusing on trying infliximab as second line, so comparing it to just giving a second dose of IVIG. And this is their most recent trial, the Kid Care trial, that looked at how fast the fever was coming down when you added infliximab or you didn't add infliximab, and certainly that was the case. But again, no difference to coronary outcomes. So how would I interpret this? Would I use infliximab in my practice? Certainly not up front, because there's no evidence to suggest it makes any difference up front, but I think it's a good option for refractory cases. Interleukin-1 blockade also has attracted a lot of interest, particularly in the post-pandemic era. There's been a number of small studies really looking at anakinra as an interleukin-1 blockade agent in these patients. And there's an ongoing study using canakinumab, which is an expensive alternative to anakinra, done in Netherlands, and we're awaiting the results. I think what we can say from these small studies is that certainly seems to bring down the CRP responses, brings down the fever, the patients perhaps go home a bit sooner, and it's well tolerated. If you give it IV, probably you get better sustained levels of the drug compared to just giving subcutaneously, but nothing is well shown from the studies in terms of improvement of coronary outcomes. So again, I think the idea is until we have better evidence, this could be an agent for refractory cases, not necessarily something you can use up front. So the SHARE guidance is a publication that was a couple of years ago now. Group of rheumatologists, infectious diseases colleagues, cardiologists, and general pediatricians produced this evidence-based but also consensus-driven guideline with the recommendations of how to manage Kawasaki disease. And I think just the highlights, so everyone gets IVIG and aspirin. I think that's what we all do in our practice. In terms of steroids, until the KD-CAP trial results are through, I don't think we can recommend them routinely for all the patients, but perhaps for some patients that we think are high risk, for instance, the babies, patients who have hemophagocytosis, patients with shock, IVIG resistance, and those who already come to your clinical practice with coronary complications, there may be a role for adding steroids. TNF inhibition, as we said, for refractory cases, and all other treatments such as cyclosporine and anakinra. There is some evidence, and on individual case basis, you can discuss the use of these agents. The American College of Rheumatology have also produced guidelines on how to manage KD. They're quite similar to the European ones, just adding, though, that they feel there's enough evidence to suggest a second dose of IVIG would be beneficial to these patients. So I thought that I'll share that. I'd like to also bring to your attention this publication from the Royal College of Pediatrics, and this is about the long-term surveillance of these patients, and it kind of gives you some tables similar to the American Heart Association guideline, but in a bit more succinct way, so you can easily refer to them in your clinical practice. And I think it's worth highlighting that definitely what this guidance recognizes is that patients who had coronary artery changes, whether these were giant aneurysms or small aneurysms, require long-term follow-up and require definitely a plan that says if you have a coronary artery event, if you're a young person, you need to be telling your doctors you had Kawasaki disease in the past. But then obviously this entity appeared and entered into our lives in the COVID pandemic era. We called it slightly differently, as I said, in the UK. And I think this is what we were sort of living at the time. We started having these reports of hyperinflammation back in April 2020. And in the UK, there was an NHS alert that kind of worried clinicians, worried patients, sort of saying, be aware, there's something that looks like Kawasaki disease, that looks a bit like toxic shock syndrome, and you're seeing patients with this post-COVID. It was interesting that initially cases were not appearing in China and other Asian countries or Japan, where essentially Kawasaki disease is endemic. We weren't quite sure how to treat this. The way we managed this at Great Ormond Street Hospital, and I'm sure that was also what you guys did here, and I know it was the case in other European countries, is put together multidisciplinary team groups. So essentially we had infectious diseases colleagues, rheumatologists, hematologists, intensivists, discussing cases on a daily basis. So at that stage, Great Ormond Street Hospital was housing general pediatric patients, and we were getting to discuss 30, 40 different cases on a daily basis. So it was really a flurry of patients with this condition that we were seeing at the peak of the pandemic. highlighting that different definitions, what's essentially different between what we used in the UK, the CDC definition and the WHO definition. I think in the UK we weren't requiring an absolute evidence of a positive test. It was okay to have some history of exposure to COVID. The CDC definition was requiring a positive test. And the WHO definition, which was more refined, and once we had started seeing more cases and understanding how this was behaving as a condition, was a bit more detailed in the actual symptoms that these patients were getting. Well, what's the pathogenesis of this? What do we think we now know about this condition? I guess you have your exposure to SARS-CoV-2, and we then think there's some genetic susceptibility, a maladaptive host response, a bit like Kawasaki disease, to clearing the virus that's not getting away and causing these hyperimmune responses. Again, the superantigen hypothesis has attracted a lot of attention with a lot of interesting papers in the field. I think the leaky gut syndrome theory is interesting, showing that superantigens perhaps are leaking from the gut to the bloodstream and prompting this immune response. But certainly other components of the immune system, such as inflammasomes, complement, B, T cells, NK cell exhaustion, and inflammatory cytokinemia have been speculated to be important pathomechanisms for PIMS-TS and MiS-C. Thrombosis, we shouldn't be forgetting about this, and we were seeing thrombotic complications in the patients as the adults were seeing in association with COVID overall. We think this was secondary to the systemic inflammatory response and this causing an endothelial activation injury process, as well as elevated D-dimers, and then seeing all these thrombotic complications. The first epidemiological study in the UK, looking at the purple dots, these are the cases of MiS-C, PIMS-TS, and they're superimposed to the background cases of COVID, and you can see they were obviously concentrated in cases where we're getting more COVID. And in terms of the demographics, mostly male patients, and they were slightly older than the Kawasaki disease patients, and really no racial predisposition. It appeared to affect everyone, perhaps a bit more black African kids in the UK, but certainly we're seeing all sorts of ethnicities being affected. And then this review kind of summarized the initial reports of patients, and again, just highlighted the same things, but had a better outline of the symptoms we were seeing. So myocarditis and toxic shock syndrome-like presentation were really key. I think also we've come to realize that the coronary changes were mainly dilatation and ectatic changes, no true aneurysms, so that's a difference from Kawasaki disease. And if you recognize this well, the patients did well. There was nevertheless a mortality of 1.6 initially, and you could get GI symptoms, you could get neurological symptoms as well. Post-COVID, a lot of people try to collect data from what we have all been seeing over the last 4 years. This is a sort of international effort, collected data from 1,000 patients, and again, kind of try to break it down into different parts of the world, see whether there are any differences. I think for me, the take-home message from this paper is that, again, what we initially felt were the demographics and the epidemiology of this disease was pretty much what we were seeing all along the next 2-3 years. I was interested in this Greek collaborative study, and I think the effort to identify factors that could show increased risk of developing septic shock, such as, for instance, being female, having myocarditis, having a severe illness, i.e. an acute kidney injury and requiring steroids, were really factors that defined an increased risk of septic shock. I like this schematic that kind of tells you what were the differences and what we feel are the differences between Kawasaki disease and MiS-C and PIMS-TS, sort of starting from the top, you know, the common symptoms, and then kind of like working your way down what was less common between the two conditions. And I think essentially lots more oromocutaneous changes and conjunctival symptoms seen in Kawasaki disease. The age of the patients, as we said, the MiS-C patients were older. In the UK, we were not seeing this condition so much in Japanese, Asian children. It looked more like toxic shock, and you could get lots of other symptoms such as GI and neuro complications. The same group that developed the diagnostic signature for Kawasaki disease attempted to do the same for MiS-C, and these are the results. Different genes, as you can see, are included in the diagnostic transcriptomic signature. And again, it worked well in the hands in terms of specificity and sensitivity, and was differentiating this condition from Kawasaki disease and definitive bacterial and viral infections. But what was the approach in terms of managing this? I've already outlined what we've done at Great Ormond Street Hospital, and I'm sure you were the same. We had to be pragmatic initially. I think this national consensus management pathway that was published in the UK, asking the opinion of all the pediatricians across the country, sort of summarized what we were doing at Great Ormond Street Hospital, and I think a lot of you were doing. So we're using IVIG first. Second line included steroids, IV methylpred, and the third line was looking at adding on other biologics that were already used in adults with COVID, tocilizumab, anakinra, or infliximab. And of course, we had to discuss all the cases individually. In the UK, we had the opportunity to recruit children into the recovery trial. This is now published, and I'll show you the results, trying to get some real evidence base of how you can actually manage this beyond these consensus opinions. And obviously, if the patient had KD or HLH, they had to get treatment for that. Thinking about antithrombotic treatment and thinking about antimicrobials. The American College of Rheumatology had a similar approach, but I think the difference was highlighting infliximab in the sort of treatment pathway a bit higher up. So they were using much more infliximab, more commonly infliximab than we were in the UK. And they have a really nice table looking at cardiology follow-up, because I think this was the key here. We were dealing with patients who had this hyperinflammatory really state and also needed regular cardiology follow-up. From this, I'm just going to pick out that the patients with severe LV dysfunction were the ones that were the American College of Rheumatology suggests were getting more detailed cardiac MRI imaging, and also perhaps a cardiac CT would be needed for those who had changes in the coronaries distally. So you could not perhaps in the echocardiogram identify what happened in terms of resolution or not for these changes. The recovery trial looked at randomizing patients and see if we could get some evidence, and I'm just straight ahead going to jump into the results. So 237 children were randomized, and I think this is a good number of children. In the first randomization, you would either get IVIG, methylpred, or usual care, and in the second randomization, TOC, anakinra, or usual care. So the results were expressed in number of days you were in the hospital. I think the highlights are that perhaps methylpred made a bit of a difference. IVIG didn't really make much of a difference. Tocilizumab certainly made a big difference. Anakinra, not so much. So I think if we were now going to treat patients again, perhaps the learning from this trial is that tocilizumab could come in this sort of treatment pathway a bit sooner, because certainly there's evidence base to suggest it was making a difference. So where are we up to now? We, in the UK, and again, I'm interested in your experiences, we stopped seeing cases. There's been a rapid decline since July 2022. I think this is reflecting the immunity, obviously, of the population, the vaccination, and the changing nature of the SARS-CoV-2 variants. And that kind of really brings me to the end, but I do think we've learned a lot from understanding how this process has been triggered by COVID. I think there's some similarities with Kawasaki disease, but we have a clearer picture on how this looks different to Kawasaki disease. We await new results for new treatments, particularly the KD-CUP trial results, and I think it's important to say for all these cases, reach out to a colleague and discuss. I think it's important to work together with infectious diseases colleagues, and I think that's been very useful in my experience, not a standalone specialty. Thank you, and there's a lot of funders and people who work with me, and thank you for asking me to come. Thank you.